Hi, everybody. Thank you so much for having us to your Congress today. We wish we were visiting with you in Argentina, but we're honored to be here. My name is Anthony Mato. I am the director of the CLL program at Memorial Sloan Kettering Cancer Center, and I am pleased to be accompanied by my colleague, who is an expert in CLL, Dr. Lindsay Roker.
Good morning. Thank you so much for having us. It's a pleasure to be here.
We know you're probably hearing so many presentations today that are formal lectures, and what we decided to do was to welcome you to our clinic here at Sloan Kettering and present some interesting cases of patients that we're seeing, and hopefully that'll inspire some conversation about what are the most relevant issues and some of the biggest data gaps for patients with chronic lymphocytic leukemia. With that being said, we're going to head into our cases, and please feel free to take notes, ask us questions after our session is over, and also bring some cases of your own.
So our first case is a 47-year-old man who comes in with Rise Stage 3 CLL. His white count at the time of presentation is 99. Hemoglobin is 8 and platelets are 101. He is Coombs negative and has no evidence of autoimmune hemolytic anemia on his labs. He has an exam and imaging at the time of his initial presentation and has bulky lymphadenopathy. So he has a 6 by 6 centimeter node in his left axilla, and his spleen is measuring 21 centimeters. He does his initial prognostic testing, which FISH demonstrates a deletion of 13q, and he's IGHV mutated. TP53 is intact for this patient. So the question really is, what do we do? What do we do with this patient? First of all, is therapy indicated? And then what would we decide on in terms of his frontline therapy?
Okay. Well, I think, it's a 47-year-old, hemoglobin's already 8, and I'm assuming this is due to marrow infiltration of his disease. I can't imagine that that lymph node and that spleen aren't causing symptoms. So I think, to me, therapy is indicated for sure here by IWCLL criteria, not even close. Additional information I would love to know here would be a little bit more about the patient's comorbidities. I think that would be helpful. I'd like to know his hepatitis B and C status. I'd love to know if any additional workup was done for the anemia, just to make sure that this isn't some other concomitant reason for the patient's hemoglobin being decreased, and maybe even whether or not this patient had a bone marrow biopsy.
So great question. So the first piece is his comorbidities. He is a totally healthy 47-year-old man, no other medical problems, very fit, is actually a marathon runner. In terms of his workup for other causes of anemia, he has been checked for nutritional deficiencies, so he is not iron deficient, B12, or folate deficient, and his copper level is normal. In terms of his hepatitis B and C status, he is hepatitis C negative, hepatitis B non-immune, non-exposed, so no history of hepatitis B there. And the bone marrow biopsy was actually deferred in this case. He has a strong fear of needles, so actually preferred strongly to avoid that test.
Okay. So, I think I have enough information. This type of patient, in my opinion, has all doors open to them. There's really no type of therapy that shouldn't be discussed, including chemo immunotherapy, BTK inhibitor-based therapy, and Venetoclax-based therapy. So it's going to be a long conversation with this patient, I think, to make the right decision.
And as you're having that discussion, how do you talk to people about kind of what the risks and benefits are of chemo immunotherapy?
Yeah, this is a tough one because this patient is young, and as far as I can tell, they have the most favorable genetic profile. I guess I should also ask you, besides next-gen sequencing for TP53, was there anything else there, like Notch1, BRC3, SF3B1, any of those things?
All of that testing was done. This was actually a comprehensive panel looking at 400 different cancer-related genes, and he didn't have any mutations in any of those genes.
Okay, so chemo immunotherapy is certainly a consideration for this patient. He's young, he's fit. There's the perfect molecular genetic profile. If this patient were to be generalized to data, long-term follow-up data from the German CLL study group or from the MD Anderson group from the 300 study, has a potential for cure. I would estimate it to be 50+% chance for cure. Unfortunately, there are also long-term risks associated with FCR. We're in a pandemic, so we could think about the CD20 antibody. And then I am sometimes worried the younger the patient, the longer the exposure time from fludarabine-based therapy, the higher the risk for developing the long-term toxicity, secondary cancers, bone marrow failure, AML. And so what I'm finding is that most of the time when I'm weighing the risks and benefits for chemo immunotherapy versus novel agent-based therapy, most patients who are even in this group are still leaning towards novel agent-based therapy. Are you finding the same
Yeah,
thing?
I've had the same conversation. I think the 50%, even if you call it a cure, 50% is still a roll of the dice. And a lot of patients do look at those long-term toxicities and really think that the, maybe easier strategies with novel agents really are more tolerable and more available to them.
Yeah, I'm finding in my clinic right now, doing chemo immunotherapy once per year or once or twice per year, but certainly it's a very infrequent event, and none of our clinical trials are randomizing to chemo immunotherapy at this particular time point.
Yeah, absolutely. If you had this patient and you were to discuss all of these options and in the end, that patient were to decide to go with chemo immunotherapy, do you check MRD, and how do you use that to decide treatment duration, or do you use that in your consideration?
So I do, and it's based on data that have come from the MD Anderson a long time ago. I can't even tell you how long ago. Retrospective data set where patients who were treated on the original studies with FCR, there were just some patients who discontinued early, probably mostly due to adverse events, who happen to have a bone marrow at cycle 3 as part of the study for response assessment. And the data did show that for IGHV mutated patients, just like this patient, if you were MRD undetectable after 3 cycles of FCR, the outcomes from the perspective of PFS were not different than if you had received all 6 cycles. So for me, it would be flow cytometry, ERIC criteria, 10 to the minus 4th as a cutoff from a bone marrow sample, which would be appropriate for decision making. With that being said, I would ask you, I haven't seen like longer term updates of those curves to verify that they did stay together. But I've always made this decision based on 3 or 4 cycles of FCR with the intent of hopefully limiting exposure to Fludara, and maybe some of those bad long-term consequences don't happen.
Absolutely. And do you use the word cure as part of your dialogue?
I mentioned that it's a possibility, although I don't overly emphasize that word when I'm discussing any therapy with patients, including FCR or allotransplant. I just talk about long-term remissions. I feel is more appropriate. Do you?
No, I totally agree. I think long-term remission is more appropriate phrasing. Absolutely.
Well, that was a good first case. Should we delve on a little bit further?
Yeah, let's do it.
Okay. So I'll present this patient. So this is really asking the question about continuous therapies versus fixed duration strategies. So this is a 67-year-old woman with a prior history of breast cancer, treated with surgery, radiotherapy, and adjuvant chemotherapy. She's then diagnosed with Rise stage 2 CLL, presents with symptomatic splenomegaly, her abdomen's full, she has early satiety, she's lost 10 pounds. And so this is a problem. She does have a prognostic evaluation that's unmutated for IGHV. On FISH, she has a deletion 11q, and she's already had enough of chemo immunotherapy. She's not interested in hearing about it based on her prior breast cancer experience. And she'd like to discuss the pros and cons of alternatives to, let's say, FCR or bendamustine rituximab. So we're living in a world now where we have Venetoclax, but we also have 2 approved BTK inhibitors. Would you just kind of educate us as to how you kind of discuss the different BTK inhibitors and guide patients as to what would be the most appropriate choice for either ibrutinib or acalabrutinib?
Absolutely. So when I'm talking to patients about their frontline treatment, I really do present the continuous BTKi strategy versus fixed duration venetoclax or obinutuzumab, and really talk about the pros and cons of each. So continuous therapy with a BTKi certainly has the benefit is really the ease of use. So it's a pill that you're taking twice a day, once a day, depending on which agent you're picking, and requires minimal kind of lab monitoring, and is a pretty, get up and go strategy. We do use it as a continuous therapy. And then venetoclax obinutuzumab does require more upfront investment in terms of monitoring and that kind of strategy, with the 9 weeks in the front end of that regimen really being quite intensive, though the benefit there is also fixed duration. Once I have had that conversation, I really depend on patient comorbidities and patient preference to help me understand which direction I should go. So does this patient have other comorbidities beside that history of breast cancer that I should be considering?
Yeah, so this patient has hypertension. They're on 2 agents, an ACE inhibitor and a calcium channel blocker. And they had a history of coronary artery disease, but no evidence of MI. They've had a stent placed successfully. This was caught on routine stress testing that was performed prior to the anthracycline-based therapy given for the breast cancer.
Okay, and that chronic kidney disease, the creatinine clearance is decreased?
The creatinine clearance is around 30.
Okay, so when I'm considering those comorbidities, that renal function really would push me more toward a BTKi-based approach. And when I'm talking to patients about, which BTKi to choose, I really do look to that history of hypertension and coronary artery disease. So we now have head-to-head data on ibrutinib versus acalabrutinib, and we know that the risk of hypertension and the risk of atrial fibrillation is lower for patients treated with acalabrutinib versus ibrutinib. So my practice, because of that data, has really shifted toward using acalabrutinib.
So can I follow that up? And that's data from the relapse refractory setting. Are you comfortable then extrapolating that to the front line?
I am. I don't have a lot of reason to think that the toxicity should be so significantly different in the frontline setting. So that head-to-head data is really the best we have in terms of the field and really comparing these 2 agents. So I do use that pretty freely in all treatment settings. Are you doing the same?
I am. I was an investigator on that study, and what I like about the data set is that it's really long-term follow-up. So the initial publication is long-term follow-up, which is different than many of the other studies that we've seen published in the past. And so I do feel confident about the AE profiles and what distinguishes one from the other. So let me just ask you a question then. Let's say you have 2 different choices, ibrutinib and acala. You also have, per at least here in the States, FDA approvals to give CD20 antibody with either agent. How do you decide, let's say with ibrutinib or acalabrutinib, 2 separate choices, whether you're incorporating a CD20 antibody?
So with acalabrutinib, Elevate-TN does show that PFS benefit of adding obinutuzumab into the acalabrutinib. I'm finding that I have this discussion with patients, and often when I was talking about patient preference really guiding a lot of my decision-making on this frontline, as well as comorbidities, patients really do like the idea of a pill-based therapy. So I end up having that discussion with patients, talking about a potential progression-free survival benefit, though no overall survival benefit. And for most patients, they do end up going just kind of with monotherapy. Okay. Is that what you're finding?
Yeah, I think in the setting of a continuous therapy, the benefit of the CD20 antibody is a little bit more questionable, although I do have to say that for ibrutinib, for me, it's been an absolute no because of the Alliance data and the randomized data from MD Anderson really showing no benefit for rituximab. The ECOG 1912 didn't have a ibrutinib monotherapy arm, so unfortunately weren't able to assess relative contribution there. And then the ibrutinib OBIN data, again, did not include a ibrutinib monotherapy. So I really can't speak to randomized data. I do find the data from Elevate-TN to be intriguing. When Jeff Sharman presented it, I think at 24 months, curves were separate, but they were still close enough that people said those curves are going to come back together. Then when he presented it at 48 months, those curves were further apart. And so it's making me wonder whether the addition of the anti-CD20, I think really will play a role clinically from a PFS perspective. When I show those curves to patients or quote the numbers, it makes them want to have the CD20. And maybe you can just also highlight our clinical trial. So we kind of bet on acala OBIN being better than acala and designed a trial. So
yeah, so we have a frontline trial that's currently open to all patients who do not have TP53 aberrations. So deletion 17p and TP53 mutations are not included in this study, but we're looking at the combination of acalabrutinib and obinutuzumab for anywhere from 12 to 24 months, and that is guided duration is guided by MRD status. So the idea here is that for patients who are able to achieve a deep response with that combination therapy, they're able to come off therapy and enter a period of treatment-free observation, kind of betting on the idea that BTK might not need to be a continuous therapy.
So certainly not standard of care, but just a little provocative in terms of what we think maybe the CD20 may add to BTK inhibitors. And then with that being said, this patient did have options, right? It wasn't only about giving a BTKi, but Venobin is an option for patients. Can you just briefly discuss a little bit more on pros and cons, and particularly focus on this patient who I didn't give you a lot of information, but let's just say the risk of TLS is either medium risk or high risk, and the creatinine clearance is decreased.
So we have real world data that do demonstrate that your risk of tumor lysis syndrome really is related to your kidney function, which I think just empirically makes sense. So for this patient who has a creatinine clearance, it's really pretty borderline. I would be much more conservative in terms of my approach to a Venetoclax dose escalation than I would be for a patient who had a creatinine clearance over 80. So I would with a patient with medium risk TLS, I would likely still keep them in the clinic setting. I wouldn't necessarily hospitalize them, but I would be making sure that I was using IV fluids and likely even some, obviously the normal uric acid prophylaxis with allopurinol, but for anyone with a borderline elevated uric acid, I'd be also using respiricase, and then watching that potassium quite closely with probably multiple time points through those dose escalations.
Okay, let's continue then. So here's some additional information for this patient. We already knew the prognostic panel. We talked about the TLS risk being medium. We talked about the creatinine clearance. So I think the decision here was to give BTK inhibitor-based therapy plus obinutuzumab. Can you give some practical impressions or practical guidance on Obin for this patient? Because we've learned a lot together over the years, and I think that there are some things that are worth sharing.
Absolutely. So for Obin, I really prepare patients to expect that infusion-related reaction on day one. And I do things to minimize the risk, and then I also do things to basically set expectations. So in terms of prophylaxis, I start allopurinol 7 days before therapy, and for this patient, it would be dose adjusted based on the creatinine clearance. Then 3 days before therapy, 2 days before therapy, I start prednisone 50, I start famotidine, and then the night before therapy, the morning of therapy, and the night of day one, I give montelukast. And that is based on a series of patients who were treated with rituximab and used montelukast that really showed a reduction in the rates of infusion-related reactions. So we've kind of adapted this for obinutuzumab and have found that it really has helped with infusion-related reactions, both the frequency of them as well as the severity. So with that pre-med regimen, I then bring people in on day one.
Can I just clarify though? So also on day one, it's Tylenol, Benadryl, Dexamethasone. You're still giving the
I'm still giving the standard
label
pre-meds in the chair. So the day of day one, they really have gotten a lot of steroid because they've taken their prednisone at home beforehand, which also offers some longer term coverage through that day. And then they get their steroid while they're sitting in the chair. The day one, I do the standard dose escalation, understanding that there's a likelihood that they will have a reaction requiring that they stop, likely be re-medicated with perhaps Benadryl, perhaps steroids, depending on the severity, and restart at half the rate. Then after the first day of obinutuzumab, I always do the split dose. I very rarely give the full 1,000 on day one. I usually give 100 milligrams day one, 900 day two. And at the end of that therapy, I give a liter of normal saline and recheck TLS labs because I do find that patients actually do lyse on that day one.
That's very helpful. I do exactly the same. I think we have a pretty uniform practice. And with that being said, we still see fairly often infusion-related reactions. I will say a learning experience for me has been on the Acala Obin trial, because the Acala, even per the FDA approval, starts a month before the Obin. And the data from Elevate TN was pretty impressive in terms of decreasing the Obin-related IRRs by about half. So that's been quite helpful
Absolutely.
to me and my patients and the nursing staff here. Okay, so you mentioned earlier that BTK inhibitors are generally easier therapies to start. I want to get your sense of dosing, what you do. Are you prophylaxing for TLS with BTK inhibitors? Do you give antimicrobial prophylaxis as your standard of care, either frontline or relapse refractory? And then, once you give a patient a BTK inhibitor, do you see them back in 3 months? Do you see them back monthly? How often are you checking labs? So like, what's your strategy?
So I start at the full dose. So for acalabrutinib, I start at 100 milligrams twice daily. And I talk to my patients quite at length when I'm starting them about kind of keeping me informed for adverse events, because I find that it's much easier to intervene on some of these early toxicities when they're minor and can be kind of nipped in the bud, as opposed to once they're a significant problem. So with the BTKIs, I start at that 100 milligrams twice daily. If patients are having issues with tolerating in terms of a headache or whatever it is, that early toxicity, then I do sometimes hold for a period, dose reduce. And even with just a few days of dose reduction, they can typically then tolerate bringing them back up to the full dose. But I do try the full dose at first, because there are a good proportion of patients who tolerate it just fine and are able to kind of sail through. In terms of TLS prophylaxis, I do not typically start TLS prophylaxis routinely. And the same goes for antibacterial prophylaxis, except in the case of patients who have had recurrent viral infections or things like that, where if acyclovir prophylaxis is appropriate, given their clinical history regardless, then I would keep them on it, but I don't routinely put people on antibacterial.
Can I ask you a follow-up then? What if you're not using a CD20, but the patient has had some exposure to hepatitis B? Let's say they're core antibody positive.
I am putting people on entecavir pretty routinely. Are you doing the same?
Yeah, I am. I mean, I think that there's I couldn't quote the literature, but I know that there is some suggestion that any of these targeted therapies can reactivate viral hepatitis B. So I'm conservative. I do start them on entecavir and follow PCRs like every 3 to 6 months to make sure they haven't reactivated, assuming the LFTs are normal. What about monitoring? So you hand them their bottle of ibrutinib or acalabrutinib, and then what happens next?
So I typically see people back in the 2 to 4 week range, mostly because I want to check in on how they're tolerating the drug. And, I'm very explicit about contacting me with any AEs, but I find that patients are still not always calling me. So that early check is really just to make sure that they're tolerating the drug well. As long as labs look okay there, then I'm pretty comfortable going to a 3-month schedule. What do you do in terms of?
I do basically the same. I usually tell patients, if I start a BTK inhibitor, I'll give them a prescription for like weekly labs usually I'll put for 8 weeks, but sometimes we cut that short, at least 4. And then I'll see them back in a month. And in the interim, I'll get weekly labs just to verify that, particularly if they had a cytopenia, sometimes they get worse before they get better. And so I want to make sure if there was like a borderline platelet count that it didn't decrease too much. And then after that first monthly visit, I might see them back in 2 months, assuming everything's going well. And then ultimately our goal is to see them every 3 months or so, and then just refill their prescriptions in between. What we've talked about AE monitoring, and so maybe in general, without going into like the difference between individual drugs, just could you comment on the general AE profile associated with the BTK inhibitor? Maybe highlight some specific toxicities to monitor for.
So I talk to patients about what are the major side effects that I worry about, and then what are the annoying side effects, basically, is how I lay it out. So the first piece is I talk to patients about atrial fibrillation as a risk. Call me with any palpitations, chest pressure, shortness of breath. I talk about hypertension and the importance of blood pressure monitoring. So for patients who have a borderline blood pressure to start with, who have a home monitor or home cuff, I often ask that for that first period that they monitor it a few times a week, just to keep an eye on it. We also know that hypertension tends to be a later event with BTK inhibitors. So it's not something that necessarily develops right in the beginning. It's the median time to kind of that highest blood pressure in real world data is about 6 months. So it is something that we have to remain vigilant about, even after starting therapy in people who are tolerating it well. And then I talk to patients about bleeding risk and the importance of calling with any bleeding, but also if there are any planned procedures, surgeries, dental work, anything like that, to call me so that we can hold drug before and after.
Can I ask you a follow-up to that though? Because I'm sure someone from the audience is going to want to know this. Aspirin, Plavix, DOACs, warfarin, are any of those a deal breaker with either of the BTK inhibitors for you?
So I really try to avoid warfarin. So if patients need to be anticoagulated, I put them on a direct oral anticoagulant. The others are not deal breakers. We just talk about the additive risk. So if you have somebody who needs dual antiplatelet therapy plus needs to be anticoagulated for a history of atrial fibrillation, and now you're adding a BTK inhibitor, those are added risks. So that might be a patient where the comorbidities would steer me more another direction.
Another question, I'm not sure that there is an answer to this, but I hear some people say, oh, if I'm going to use a BTK inhibitor plus a DOAC, I like sort of cut the dose of the DOAC in half. Do you modify any of the drugs based on the potential interaction for bleeding risk?
I have not. Do you do that?
No, I don't, but I've heard of others saying, okay, I'm going to give the DOAC at half dose because there's compensation by the BTKi. I actually think it's the wrong management, but I'm just curious if others are doing that.
Yeah, the other piece is for patients where the dual antiplatelet indication is somewhat borderline, right? There are those patients who are years out from a stent placement and are still on DAPT. Those are the patients where I do talk to their cardiologist about whether the risk of cutting out one of the antiplatelet agents is actually worth it once I'm adding a BTK, and I try to be attentive to that.
Any other toxicities to mention?
I do talk to patients about rash and arthralgias, as well as the headaches with acalabrutinib specifically. So from the rash and arthralgia perspective, I kind of bring it up as something that might happen. Call me if it does, because we have strategies for mitigating that. The headache I talk about as being very caffeine sensitive. So I tell patients, take your acalabrutinib in the morning with your coffee and then take it before bed. And I talk about using a caffeine included headache medication if that does occur. I really find that goes away after the kind of the initial period of the drug. So I tell people that by 6 weeks they're going to be feeling better, and that does provide some reassurance for patients.
So do you give all your patients this MSK mug so that they can?
I am a strong coffee believer. Yes.
Yeah, okay.
Absolutely.
And then just last question, yes, no, is there any role for MRD monitoring on BTK inhibitors?
So we had talked about the strategy that we're using in a clinical trial where we're monitoring MRD status as a guide point for treatment duration. In routine clinical practice, I do not test MRD because I use BTK inhibitors as a continuous therapy, so that MRD really isn't going to affect my strategy.
Completely agree with you. All right, let's jump to the next case. I think this is one that you were going to present.
So this is a 77-year-old woman who was diagnosed with Rise stage 4 CLL. At diagnosis, her platelets are 75, and this is due to marrow infiltration, not ITP. So she has had a bone marrow that looks like her marrow is just replaced with CLL rather than having some megakaryocyte increase. And her history is notable for controlled hypertension, controlled atrial fibrillation. She's on diltiazem and apixaban, and then osteoarthritis in both knees. She has FISH studies that show a deletion of 17p, and she doesn't have access to Venetoclax based on the approvals in her home country. So she is going to pursue BTKi based therapy. So in this patient, would you use ibrutinib or would you go to acala?
I would likely go with acalabrutinib for this patient. Couple different reasons why. Number one, platelets are sort of lowish to start with, and makes me always worried about a potential risk for bleeding with thrombocytopenia, being on apixaban plus starting a BTK inhibitor. So that would be one. The hypertension history is one that I do care about. I do feel, regardless of whichever BTK inhibitor, there's a risk of exacerbating hypertension, but the head-to-head data showed a lower rate of hypertension with acala. Although, we're going to talk about this, I guess, in a little bit later part of the case, but we have to pay close attention to what meds she's on. The osteoarthritis of the knees is concerning to me. I have found in the past, more with ibrutinib than acala, that like underlying arthropathies or tendinopathies tend to get exacerbated further. So I'd be worried that, sort of sources of inflammation will become more inflamed. And I think those reasons together would support the ACALA. The only thing that one might argue is that we have more data, although it's not large prospective data sets for del17p disease with ibrutinib versus ACALA. But to me, I think it's a class effect that these drugs are active in these patients. And so I wouldn't probably distinguish one BTK inhibitor versus the other.
Fair enough. Looking at this med list, what drug-drug interactions are you thinking about and how is it going to affect your dosing?
Well, the diltiazem is a CYP3A4 inhibitor, and to me, that's a concern. I find that there's so many patients out there on diltiazem who have AFib, which I think is sort of a remnant from prior more historical management strategies for AFib. Probably I'd try to get on the phone with the cardiologist and see if this patient could be switched to a beta blocker would be my first choice. But the DILT and the ACALA do interact, and so I would, again, my strategy would be to get them on something else and try to do ACALA at full dose. Otherwise, that could potentially be a problem. I will note it's the same problem with ibrutinib and Venetoclax, and so you basically need to address this one way or the other. There is no BTK inhibitor, to my knowledge, that's approved, or Venetoclax that wouldn't have basically the same drug-drug interaction.
And with her history of osteoarthritis, she asked you, she says, NSAIDs are really what works for my joint pain. Can I still take NSAIDs?
I say yes, but I often say hopefully the platelets will come up first to kind of eliminate that one issue. I'm a little bit conservative and I just say very sparingly NSAID use, but I don't absolutely prohibit it, although it does, like you mentioned earlier, probably increase the bleeding risk for a patient like this.
And what is the data supporting low dose strategies, and do you ever use that?
Well, that's a good question. I haven't seen really any data yet for like people starting ACALA at low dose in practice, meaning like once daily or something along those lines, mostly because the PK for ACALA really does support it being a twice daily drug. But there has been a literature, we published something in partnership with some other centers, and MD Anderson has published data, and I'm sure others have as well, looking at starting ibrutinib at lower doses. My general take on the data set in general is that I would not advocate for starting it at a low dose, but I do feel that if you have to lower the dose early on because of an adverse event, and that's kind of what we've been talking about, or more importantly, due to a drug-drug interaction, that there's no compromise for patients. And so I have not jumped on the bandwagon to say like do weight-based dosing or start everybody at 280 milligrams of ibrutinib, but I do feel pretty comfortable if I have to lower the dose due to an AE that the outcomes will be okay.
Perfect.
Let's jump to the next case. So this is now we're going to talk about sequencing of therapies, and this will be a little bit more of a speedy part of the presentation where we'll kind of just jump to some relevant questions when we're thinking about how to sequence agents. And this really ties into how BTK inhibitors fit into the sequence overall. So this is a 75-year-old patient who's IGHV mutated, trisomy 12 positive CLL. They've been treated with several lines of therapy. First line was bendamustine rituximab given in 2016. Second line was ibrutinib rituximab given in 2019 in the style of the ECOG 1912 regimen, although it was discontinued shortly thereafter in the setting of significant rash and arthralgias. And so this patient has progressed 2 years later, and I think you or I should highlight that the remission did last for 2 years before they needed another therapy, again, supporting that potential time-limited approach. 2021 comes around and we need another therapy. So I want to ask you some scenarios. So number one, in this setting, is there a role for an alternative BTK inhibitor in the setting of intolerance?
Absolutely. So when I think about what I'm going to use after a BTKi based approach, I really do think about why they stopped that initial BTKi. So for a patient who discontinued for intolerance, like this patient, there is a role for an alternate BTKi. So that has been studied prospectively. Both acalabrutinib and zanubrutinib have been studied in patients with prior intolerance to another BTKi or B-cell receptor inhibitor. And that seems to be a tolerated approach with relatively minimal recurrence of the same side effects. So I would definitely think about that for this patient.
And I'm guessing that the toxicity that led to the discontinuation might dictate whether you would do this or not. If it's a major hemorrhage or life-threatening
Absolutely.
ventricular arrhythmia, would you still do that?
No, absolutely. So rash and arthralgias, I feel pretty comfortable retreating. If it was a patient who had, ventricular tachycardia or nearly fatal bleeding event, then obviously that risk benefit is very different.
So that brings me to the next question. Same question, BTK inhibitor intolerance, is there a role for PI3K inhibitors, real world or clinical trial data?
So clinical trial data, there is a study that you published we published on umbralisib in patients with a prior intolerance to a B-cell receptor inhibitor, and that appears to also be a very well tolerated approach. So umbralisib is not approved for the use of CLL, but does seem to be tolerated in this patient population and has efficacy in this patient population as well.
The median PFS was about 2 years, and the discontinuation rate there due to AE was about 12%. So I agree. What about chemo immunotherapy? So they got BR, they got ibrutinib, and now you want to circle back to chemo immunotherapy.
So chemo immunotherapy has really not been studied in this strategy, in this setting. So the data on chemo immunotherapy, there basically are 0 novel agent treated patients in any of these studies. So, and the other piece is that we have the relapse refractory data of acalabrutinib versus investigator's choice of a PI3K or BR, and acalabrutinib is certainly superior to that investigator's choice arm. So I really shy away from chemo immunotherapy, especially for this patient who has so many options.
Yeah, and I would add to that we also have the VEN-R versus BR data, which another nail in the coffin for chemo in the relapse refractory setting. And then of course, before any of these novel agents came out, there were patients who were treated with multiple lines of chemo immunotherapy. And every single line, the remission durations got shorter, not longer, and the risk of bone marrow toxicity goes up. So I agree with you, it's out. What about Venetoclax here? What do you think?
Yeah, certainly an option. So I would talk to the patient in the same way that I talk to them in the front line about kind of trialing another BTK versus going with Venetoclax-based approach and kind of risks and benefits of each of those.
And I also want to bring in the conversation about real world data. You're an expert in research and real world evidence in CLL. You've published several papers. Can you comment on how the real world data from our group and others around the world have really contributed to our knowledge on how to use BTK inhibitors?
Yeah, so we know that the most common reason for discontinuation of a BTK inhibitor in about half the cases is toxicity. So that has been shown in several real world studies, and we really do know that toxicity is a leading cause of discontinuation. In terms of sequencing, we have real world data to support both the sequence of BTK to Venetoclax as well as Venetoclax to BTK. There are real world series supporting both of those sequences. So, and that's really the data that has allowed me to freely support either in the frontline setting. In terms of indirect comparisons, so there has been some intriguing data in the relapse refractory setting looking at BTKi versus Ven as the first novel agent used in the relapse refractory setting. So this was a chemoimmunotherapy treated population who's now going to receive their first therapy. And it does appear that there's a progression-free survival benefit for a BTKi versus Venetoclax, but there is no overall survival difference. So because of that lack of overall survival difference, I think you could justify the use of either, but there is some hypothesis generating data suggesting that BTKi might have a progression-free survival benefit. Same can be said for BTK versus PI3K. So the real world data would suggest that progression-free survival benefit of a BTK inhibitor versus a PI3K inhibitor.
Excellent. Let's go on to a few more questions relevant to cases. And maybe do you want to guide through this one?
Absolutely. So this is a patient who received BR in the front line and then ibrutinib rituximab. However, this patient, instead of discontinuing for toxicity, has now had a progression event. So they discontinued this year because of an acquired CYS481 mutation, as well as a deletion of 17p that was detected on FISH. So for this patient, would you consider another covalent BTK inhibitor?
No way. So I think we know enough from preclinical data, from data generated from OSU, from several real world data sets that going from one covalent BTK inhibitor in the setting of clinical to another in the setting of clinical progression won't result in a durable remission. So to me, there's no benefit of going from ibrutinib to acala or acala to ibrutinib or zanubrutinib. I think that part of the sequencing algorithm is done.
And how about PI3K in the setting of BTK resistance?
Yeah, it's not as well studied, but we did have at least one real world data set where we looked at essentially ibrutinib to idelalisib in the setting of clinical progression, and the remission durations were short. I think it was under 9 months. I think it was around 7 or 8 months. So probably cross resistance between the two, particularly I would guess in the setting of PLC gamma 2 mutations, but it could be both. So I generally don't favor that strategy if possible.
And how about the real world evidence for Venetoclax in this case?
Well, the best data we have for Venetoclax following BTKi from a clinical trials perspective is the Ven monotherapy, which was published by Jeff Jones, and that did support Ven even in the setting of clinical and clinical resistance and having a known CYS481 mutation. Median PFS there was 2 years. We've co-published data from real world looking at Ven following a BTK inhibitor, regardless of the reason for discontinuation. It looks to be an active choice.
And is there a role for a non-covalent BTK inhibitor in this case? And what are you looking at in terms of agents there?
Yeah, so in our group, we've been working with the LOXO 305 pirtobrutinib molecule as contributors to the Bruin trial, and have, this molecule was designed to be a highly specific BTK inhibitor that, based on its binding mode and location, could overcome CYS481 mutations. And the early clinical data looks to be quite promising.
Excellent. So not yet approved, but a good option for patients.
Not yet approved,
in
but
the future.
As we're about to start our clinic, we'll probably have a patient on that molecule in this exact situation. So then just to our final questions, I'll present these to you. So similar story, BR, ibrutinib rituximab. This time the patient discontinued in the setting of BTK inhibitor associated intolerance. Here it was AFib, and let's say this was a pretty significant AFib event, grade 3 or 4. The patient decided to have Ven-based therapy, got the Murano regimen, 24 months fixed duration schedule, but ultimately progressed. And so this patient has had BR, IR with AFib that's now well controlled, but wasn't at the time, Ven-R, and now needs another therapy. Can you comment on BTK, covalent BTK inhibitors and PI3K inhibitors in this situation?
So the history of atrial fibrillation always kind of gives me pause, but I don't use it as a deal breaker for a future covalent BTK inhibitor. So I would work very closely with their cardiologist in this setting, but that would really be, because that was a prior intolerance rather than a progression event, that's probably the most active agent for this patient at this point. So I would work closely with their cardiologist and attempt to get them probably on another BTK inhibitor, either covalent in a standard of care setting or non-covalent in a clinical trial setting.
And then what about PI3K inhibitors in the double novel agent exposed patient population?
So we have data looking at PI3K inhibitors after Venetoclax discontinuation in a real world series. And there it does not appear to be a very durable strategy. So might be used as a bridge to getting to something else, but I wouldn't look at that as kind of a destination therapy.
So then what's the difference between the PI3K inhibitor clinical trials and the real world data? Why that gap in terms of PFS?
Fabulous question. I think there's a series looking at the comparison of idelalisib in the clinical trial setting versus a Medicare population, and there is a progression-free survival detriment in the real world population. And there are a couple of hypotheses for why that might be. It seems like there are fewer dose reductions and there are fewer dose interruptions in the PI3K class. So people might be having toxicity that's not appropriately managed if you don't have kind of the rigid structure of a protocol to kind of help guide that.
And a little bit of a read my mind, but I was also thinking like the Idela and Duva and even the umbralisib data sets all excluded patients who got BTK inhibitors and Venetoclax. So we really don't have clinical trials where these drugs have been studied in this particular setting.
Yeah, absolutely.
Two other just brief questions before we conclude the session. So what about Venetoclax as a retreatment? This patient got a 3 or 4 year remission. Would you support that? Is there data to support that?
Absolutely. So there are a couple different pieces of data that I would use to think about that. The first is that there are patients who were treated on Murano on the clinical trial who have subsequently had Venetoclax retreatment, and the overall response rate there seems to be about 75%. There's a real world data series from our group as well that supports exactly the same overall response rate between 70 and 75%. So certainly Venetoclax based retreatment is a completely reasonable option for this patient.
And then I also wanted you to comment on allo transplant. I mean, up until recently, we had really very few data sets on allo after novel agent-based therapy. You published one in Blood Advances a couple of years ago. Can you comment, if this patient were 55 and had had BR, ibrutinib, venetoclax, is there a role for allo? What do the data look like?
Absolutely. So it does seem like there is a role for allo in this patient population, the young, fit patient. And it does seem like the comorbidities really should guide decision-making. So for a young, fit patient, this is still a very tenable strategy after novel agents. We looked at which agent was used leading into the transplant. So whether that's a BTK-based approach or a venetoclax-based approach, and there doesn't seem to be a significant difference between the two. So I think either strategy would be reasonable. But for a 55-year-old, I think it's at least worth a discussion.
And then final question about allo, what does the PFS look like?
So there do seem to be patients with long-term survival. So it's about 75%, kind of with a 2-year follow-up mark.
Got it. Well, I wanted to conclude, and then I'll give Lindsay the final word. Just thank you so much for attending this session with us. I was a little bit off the cuff, but we really wanted to discuss what the issues are to be most relevant to us when we're seeing patients in clinic. We're going to now transition over to a Q&A session, and hopefully our conversation has inspired some questions about your own CLL patients or how you're interpreting the literature. And Lindsay, I'll give you the final word.
Really looking forward to a great discussion. Thanks so much for having us this morning, and we look forward to it.
Thank you very much.